A very good evening to all my dear MOS members and the ophthalmic fraternity who have joined today. This is the first of the MOS academic committee meet. Well, the subject today is preferred practice guidelines in ophthalmology, how to go about it. Friends, as I took over as the president in November, I had made 21 committees, and for the academic, I had in mind that we should have a preferred practice pattern for our MOS members. Well, American Academy already has it. Shankar Netralai, my alma mater, did it way back in 2010, and we had a revised edition, out of which Dr. Mohan Rajan has been kind enough to send me that copy, and it is fantastic. It will be a ready reckoner for each one of you to follow it up, because we have different ways and different institutes teaching a different protocol and different guidelines for the treatment. And today we have an expert to guide us how to go about this. Dr. Mohan Rajan, my close friend. We were co-fellows in Shankar Netralaya in 1986-87, and he's been there and always a good guide to me also. He is also the Tamil Nadu Ophthalmic Association president. And more about his intro, my co-moderator, Dr. Praveen Patil, is going to tell about in detail. We have two prominent in-house faculties with us who are as the co-panelists. We have Dr. Rajul Parekh and Dr. Akshay Nair. Dr. Akshay Nair is from Shankar Netralaya, ex-SN fellow, and Dr. Rajul Parekh is a glaucoma consultant. More about their intro by, again, Dr. Praveen Patil as the session goes on. I now welcome you all today on a Valentine Day to enjoy this lovely session by not only a good speaker, but a good entertainer also, none other than Dr. Mohan Rajan. So over to you, Dr. Praveen Patil, for further this thing. Yeah.
Good evening, sir. It's my pleasure to introduce Professor Dr. Mohan Rajan, sir. Sir is a specialist in both anterior and posterior segment surgeries. He has made more than 2,000 presentations, national and international. He has performed more than 130 live surgeries across the world, and he has several innovations to his credit, like Punchorexis, Mohan Rajan Chopper. Everyone is using that. He has delivered 27 named orations and published 46 publications in various journals. He has won several Best Video Awards from various international organizations like AAO, APARS, ASCRS, ESCRS, APAO, WOC, etc. He has received more than 60 awards and the Best Doctor Award twice from Government of Tamil Nadu. He has trained and mentored more than 500 ophthalmologists around the globe. And he is also winner of 55 ophthalmic Premier Leagues till date. Recently, he has won 2 more premium of the Premier Leagues. So it's 57 now. It's a world record. Over to you, Mohan Rajan, sir. We are eager to hear about preferred practice patterns. Over to you, sir.
Shall I share my slides?
Yes, boss.
Sure, sir.
Thank you very much. Are you able to see my?
Yeah. Put it on the. We can see your screen, desktop screen, the laptop screen.
Able to see maybe?
Yeah. Absolutely, okay. We can hear you properly. Screen is crystal clear. Go ahead.
See me, able to hear me. That's fine. First of all, let me wish you all a very happy Valentine's Day. It's very, very important to have a very good Valentine in your life. I don't know. And this Valentine's Day is also a very important day for all of us. Since morning, I've been getting about 15 phone calls from different Valentines. So I do not know which phone call to take. So it was very confusing, but anyway, good. It's good to have a Valentine's Day. And on this important day, I thought it's a very important topic also, because this is a topic which nobody has ever dealt with till now, the preferred practice patterns in ophthalmology. And I'm very, very thankful to my very dear friend, Jignesh Taswala, the president of the Maharashtra Ophthalmic Society, the most dynamic president, I would say, the entire team of the MOS. Here, Dr. Praveen Patel, Dr. Rajiv, Dr. Rajul Parekh, and Dr. Rajesh Joshi, and Dr. Akshay Nair, my very good friend. He is in fact an inspiration for all of us from Shankar Nethralaya for the way he's doing his work. So I'm going to just give you some broad guidelines in the next 20 or 25 minutes about what is this preferred practice patterns. The preferred practice patterns is nothing but a broad guideline which will give you and the use of technology to aid without replacing the clinical judgment. That is very important. It is a evidence-based medicine. Nowadays, evidence-based treatment. So evidence-based medicine. What is evidence-based medicine? Everybody is telling evidence-based medicine, talking about. This evidence-based medicine is based on so many factors, which I'll be talking about, and which is on the research, on the committee, the peer review, the external agencies, and so many other factors are coming into play. Now, look at the terminology. The preferred practice patterns actually the terminology coined and owned by the American Academy of Ophthalmology, the AAO. They have preferred practice patterns on various conditions. For example, idiopathic epiretinal membrane, vitreomacular traction, what is the preferred practice pattern? Okay. This is only a broad guideline. For example, cataracts in adult, cataract surgery in adult patients. What will you get in pediatric patients? What is the preferred practice pattern? This is a broad guideline, which is the PPP, which has been actually done by the American Academy of Ophthalmology. Then we have our own alma mater, Shankar Nethralaya, which is really a wonderful, I would say, it's a gold standard book everybody should take. It was released, as Jignesh rightly said, in 2010 by Dr. Prema Padmanabhan and Dr. Badrinath at that time. And it's a clinical practice patterns in ophthalmology. And this covers, if you see the book, you don't have to read any of the book. From A to Z, it covers everything. All the even procedures like removing a foreign body from the cornea. Procedures like doing a lid tear and something like that. No, everything is available in this. And what are the drugs to be given for a patient who's got kidney disease? Everything is a preferred practice. Patterns are available in this beautiful book, I would say. And I had given, in fact, I sent a book to Jignesh. The AAOS is also not far behind. In the sense that the AAO has also come out with what is called preferred practice guidelines. Okay. Because the preferred practice patterns, as it is something like a patent by the American Academy, you can't take it. So you have to probably have similar ones. There's a preferred practice guidelines, for example, on myobone gland dysfunction, on strabismus, on pediatric cataracts, and so many other, for glaucoma, angle closure glaucoma, and so many other important topics. The AOS has also got guidelines. And even endophthalmitis treatment, the AOS has got guidelines and preferred practice guidelines. These are the guidelines, they're all same. Ultimately, the end of the day, the meaning is the same. What are these preferred practice patterns? Guidelines which are formulated to identify the characteristics and components of quality eye care, number one. They're mainly to provide guidelines for the pattern of practice, not individualized for each patient. Please understand. It is not customized for each patient. It is a general overall guideline that if you have this problem, this is probably the preferred practice of pattern. Okay. And based on the best available recent scientific data, not the scientific data which is about 10, 15 years back on that particular, because so many things have changed. For example, the treatment of the macular degeneration, wet macular degeneration, there is a 360-degree change as far as the treatment protocols are concerned. The treatment of diabetic macular edema, there is a 360-degree change again. You know, everybody, even treatment of glaucoma also, there is a huge change. So everything has changed. So it is based on the best available recent scientific data. Again, these statements are intended to optimize the patient care, derived from systematic review of scientific evidence. Also assess the benefits of available treatments and alternatives. Enables healthcare workers to formulate individualized treatment plans based on his or own preferences. So it is important that you take these preferred practice patterns and follow them. Okay, you need to follow them, but you need to also use your common sense in that particular patient, in the particular scenario as well. The principles of development are: establish the transparency, number one, manage the conflict of interest, and formulation of a guideline development group. Again, I've been telling Jignesh, you need to formulate a guideline development group. You need to form in various subspecialties in ophthalmology. For example, in cataract, glaucoma, the oculoplasty, or something like that. So you need to formulate. Rate the strength of the recommendation. The grading of the recommendation is very important. The strength, whether it's a poor quality, good quality, or moderate quality. Compilation of the recommendation into practice guidelines. Again, the recommendation has to be implemented in practice, in clinical practice. You just cannot give a recommendation which is only theoretical. It has to come for the clinical practice, which is going to help the clinician who is going to treat the patient. Regular updates as and when new evidence is published. So this again, regular update, keep on updating, upgrading your PPP as well. That is the reason why Shankar Netralaya, 2010, they came out with the first edition. Subsequently, a few years back, they came out with the second edition. The second, if you see the second edition and the first edition, there is a huge change. Okay, because a lot of things have changed in the almost 7 or 8 years. In the way we see the diseases, way we treat the diseases, and where we diagnose the diseases as well. So everything has changed. You all know. So you need to constantly upgrade and update not only the technology, but also the treatment modalities which are necessary. Now, what are the guidelines for the PPCs? Feasible, measurable, and achievable. Number one. Number two is strength of the evidence and magnitude of the benefit should be sufficient to justify implementation inclusion. Okay, you cannot just say that I have just done a study for 1 or 2 patients or 10 patients, and this is going to be the preferred practice pattern. You need to have a good sample size for you to know exactly what is preferred practice pattern, whether we can recommend those for that particular condition. The preference to practice with stronger supporting evidence, maximum impact on the outcomes. Again, very, very important. Maximum impact on the outcomes. Suppose you give anti-VEGF for a patient with diabetic macular edema. Okay? What is maximum? Or you give a steroid for a diabetic macular edema. Which is the preferred practice pattern? Which has got the maximum impact on the visual outcomes? Ultimately, the outcomes are very, very important for all of us. Should also guide practitioners in effectively implementing them. Implementation of these PPPs or the preferred practice guidelines or patterns is very, very important, because unless you implement, these PPPs will not become popular. Again, what are the guidelines? It has to be patient-centered, determining who should provide the care, whether it's a primary physician or the specialist. External review is very important. Peer review, as I told before the publication, peer review is very, very important. Okay, this peer review is again very important because the peer review will give us a holistic view for this preferred practice pattern recommendations. The process of review and regular updates is also very important. As I told you, they cannot substitute the individualized clinical judgment appropriate for the clinical situation. An individualized clinical judgment is not. For example, one surgeon will say, no, I have done this. I have done given intravitreal injections for a patient who had endophthalmitis with only 1 meter vision, and the patient did what? It's the individualized clinical judgment. That is not going to be the thing. That is not good. If you have a patient who's got severe vitreitis and 1 meter vision, obviously the preferred practice pattern is to go in and do a pars plana vitrectomy for this patient. Again, not medical standards to be othered in all situations, not for the care of a particular individual. It is not for the care of the particular, it is for the care of all the patients who are going to be under your umbrella. Who formulates them? A committee of experts of the specialty, subspecialty from premier institutes of the country. Now we have subspecialties in ophthalmology. I'm very happy to say, but 20 years back when I was doing, 30 years back when me and Jignesh were doing VR fellowship, at that time it was only the retina fellowship. VR fellowship was available. Now every subspecialty has got a fellowship, and everybody is trained. Like for example, a cornea fellowship, pediatric ophthalmology fellowship, and ocular trauma fellowship, posterior segment, medical retina, UVR. So many things are there, and refractive surgery, and it's not only the cataract but also all other subspecialties, glaucoma, everything has come up. National ophthalmological societies, for example, AAOS or Maharashtra Ophthalmological Society or the Tamil Nadu Ophthalmology. I'm just giving examples here because I'm from TNOA and you are all from MOS. And prior to topic nomination, potential collaborators are contacted, maybe involve external organizations. This is also very important because it's like an external auditing. You have a preferred practice pattern guidelines, you have a committee, an external organization, and which is saying we should review your committee, find out, okay, are this preferred practice patterns, are they going to be useful for the particular for the clinician in treating the particular problem. Selecting a topic relevant to the current practice and the ophthalmologist. Lack of pre-existing guidelines for the same topic. Disease pathologies with newer advances in diagnosis and management. As I told you, age-related macular degeneration, number one. Macular hole. We never used to treat macular hole, but nowadays there's a totally different ball game as far as macular hole is concerned. Again, if you take oculoplasty, I'm sure Akshay will roll out a lot of new indications for that, which has completely changed the whole thing. Okay. Similarly, in glaucoma also, I'm sure Rajul will be able to tell us more about it. Glaucoma also, there are a lot of newer indications, newer modalities of treatment. So disease pathology, the newer advances in diagnosis. For example, the cyclo-GCs has come here, which is a micropulse laser for patients who have got glaucoma. So all these things are the preferred practice pattern, which has to be included now and then and updated. Now, the formulation of guidelines is based on appropriate users, appropriate patients, and appropriate situations. So these are the three things which you have to always remember: the users, the patients, and the situations in which these are used. This should include the explanation of the reason for recommendation, description of benefits and risks, and summary of relevant available evidence, explanation of the values and preferences that went into the inclusion of the recommendation. Again, very important. Why this particular patient, for example, why we suggest this particular patient or end ophthalmologist will require intravitreal injections, antibiotics at this stage, and why pars plana vitrectomy. You need to have what is called evidence-based medicine, and that is why we are talking about evidence-based medicine here. Okay, if you have an advanced end ophthalmologist, go in for a vitrectomy. If you have early end ophthalmologist, go in for a intravitreal injection. So that is what the recommendations should have what you call explanation of the values and preferences, rating system for the level of evidence, and strength of the recommendation. Strength of the recommendation is also very important. This is called the PICOTS format as far as the preferred practice patterns are concerned. That is the patient, the intervention, the comparison with the other alternative methods which are available, similar methods which are available. How your method, what you are advocating is superior to the comparable or what you call the alternative modalities of treatment, outcome of the treatment, the time frame in which the entire thing has been formed, and the study design is also very important. So this is called the PICOTS format, which is again very important: patient, intervention, comparison, outcome, time frame, and study design. Clinical practice answer the following questions in the specific setting. How to base the recommendations? The body of evidence, quality ratings are defined. The grading of recommendations, assessment, development, and evaluation. That is called the grade. So grading of the recommendations is very, very important. So when the committee forms, they have to grade the what you call the recommendations. The recommendations are graded on three qualities. That is the good quality, wherein further research is unlikely. For example, you know that in a diabetic macular edema, chronic diabetic macular edema, injection of Osidex or steroid dexamethasone implant is probably the best way to go in, and because that is probably the gold standard treatment today, if it is saying. So that is a further research is unlikely in this, and confidence is in the estimated population. That number one. Number two is the moderate quality. The moderate quality is further research is likely to have an important impact on our confidence in the estimate of effect and may change the estimate. So further research is likely to be, for example, that then you grade it as moderate quality. Future, there is possibility of this preferred practice, what we have suggested today, is likely to change in the few years to come. Okay, for example, we are giving now anti-VEGFs for wet macular degeneration of the CNVMs. But future, however, 2-3 years down the line, this is probably going to change to something else, which is going to be a long-acting already A-flap receptor has come, something similar, which is going to be there. Instead of giving every month, it is going to be given every 6 months. So all these are going to go. So this is got the further research is likely to have an impact, and this will probably be the moderate quality. Insufficient quality, you grade that as insufficient quality. Further research is very likely to have an impact on the confidence in the estimate of effect, are likely to change the estimate. Any estimate of effect is very uncertain. So whatever you're giving today is probably not 100% foolproof in that. So future it may change, because this is going to be a changing. It's like a different ball game every year, every few months. It is going to change. That is insufficient quality. So the grading of the recommendation is also very important. Assessment of the quality of the recommendation. Good quality, moderate quality, or insufficient quality is also very important. And as a clinician, we should know, and we should know that these are the qualities which have been recommended. Now, we have a strong recommendation used when the desirable effects of an intervention clearly have outweigh the undesirable effects or clearly do not. So you see, have a discretionary recommendation used when the trade-offs are less certain. For example, either because of low quality evidence or because evidence suggests that desirable and undesirable effects are closely balanced. So you should have a strong, if you have a strong recommendation, you know that this particular treatment, giving an intravitreal Osidex in a diabetic macular edema, is going to have definitely a good outcome in this patient. Okay, whereas discretionary, you do not know, you're not sure, it may or may not. So it's a discretionary recommendation. This also will be able to do that. Again, the level 1, level 2, and the level 3 recommendations are also there. The level 1 includes evidence obtained from at least one properly conducted, well-designed, randomized control study, RCT. It includes meta-analysis of randomized controlled trials. That is level 1. Level 2 includes evidence obtained from the following: well-designed controlled trials without randomization, well-designed cohort or case-controlled analytic studies, preferably from more than one center. It's a multi-centric, multiple time series with or without the intervention. Level 3 includes evidence obtained from one of the following: descriptive studies, case reports, reports of expert committees, organizations, example, PPP, panel consensus with external peer review. So these are the 3 levels, again, we need to go through before you recommend these guidelines for the clinician. So necessity of the rating the recommendation. You practice the guidelines, and the people who use them can draw conclusions implicitly or explicitly, help prevent errors in implementation and outcomes, and facilitate critical appraisal of the recommendations. So it is very important that as a committee, we should be able to, rate or grade the recommendations, depending on whatever recommendations you are giving, so that the clinician should be aware, good quality recommendations, we can actually close our eyes and do this. Okay. Whereas the moderate quality and other things, we need to use our common sense, use our clinical acumen, and depending on the patient's condition or whatever it is, you use your discretion and the clinical judicious use of your clinical acumen is also very important. The factors influencing the implementation are specific, limited number, published through a journal, newsletter, organization which has a maximum reach among the practitioners, dissemination through marketing. So the marketing is also very, very important for you to know, for everybody to know about this preferred practice guidelines. And that is the reason why Shankar Netra has brought out a book. I only wish that this book was available. Then this book is not very costly. It's only 750 rupees, this book. And if you if you're able to get this for everybody, we can get even a cheaper rate from Shankar Netralaya, from the publisher. That is not a very major issue. So let us see the overview. The overview is formation of a committee of experts. This is what I'm recommending to Jignesh as the president of the MOS, as a formation of committee of experts. These experts will have different committees. The committees will have, for example, subspecialties like glaucoma, oculoplasty, cornea, refractive surgery, cataract, pediatric ophthalmology, retina, medical retina, surgical retina, whatever it is. You have an experts in each of these. Now that all the subspecialties super specialties are also available. Then selection of the topics, very important. What are the topics you're going to give? Select. Are you going to deal with the topics which are already have missing, or deal with something new, which is also giving a lot of changes, for example, like macular degeneration, or the way we treat the diabetic retinopathy, or so many other things which are coming into play. Then formulation of recommendations and guidelines by the committee. So again, and the grading of the recommendations. The grading, as I told you, whether it's a good quality, moderate quality, poor quality, level 1, level 2, level 3, all these things have to come under the grading of the recommendations. Once you do that, then you have the internal review, and then the external peer review, and the dissemination of the guidelines. So the step 1 is the formation of committee. This has to be done. Step 2 is the selection of a relevant topic. Step 3 is the formulation of recommendations and guidelines for the committee. Step 4 is the grading of the recommendations as per the evidence in literature. And step 5 is the internal review. The internal review has to be done, and this has to be formulated by means of an internal review, and external and the peer review. The peer review has to be done. It's just like your peer review of your article which is being published in a peer-reviewed journal. So somebody else will review your journal and find out what is wrong on that. Similar to that, the recommendation has to be done by a peer review. Again, dissemination of guidelines is very important. Dissemination, we have several ways of dissemination. For example, you can do it through newsletters, or you can do it through social media, or you can do it through mails, or you can do it through textbooks, or you can do it through other ways of advertising, wherein the dissemination of guidelines to all the practitioners is also very important, so that all the practitioners will get the benefit of this PPP. So let us go through some examples. For example, if you have ptosis, I'm sure Akshay will be able to see. These are the things which you have to see in the history. Age of presentation, precipitating factor, worsening, duration of stable ptosis. These are all the practice. Examination of ptosis, look at the facial asymmetry, periocular skin scarring, visual acuity, refraction, pupillary, extraocular motility, pupillary evaluation. Examination, again, measurements, palpebral fissure, margin reflex, MRD1 and MRD2, and LPS. I'm just giving some examples. Look for the margin crease distance, lid lag, lag ophthalmos, Bell's phenomenon, Marcus Gunn jaw winking, fatigability to rule out find out whether the patient is having any myasthenia, corneal sensation, ancillary tests, phenylephrine test, Schirmer's test, eyes test, and congenital ptosis, early surgery, Marcus Gunn phenomenon, all these severe ptosis. I'm going through it very fast because just to give examples, what are the preferred practice guidelines which are available in the book, which is there in Shankar Netralia. Again, aponeuritic ptosis, neurogenic ptosis, myogenic ptosis, traumatic ptosis, and postoperative management. This all everybody knows about it, but just to give an example. Again, in intraocular foreign body, rule out life-threatening systemic injury requiring immediate attention. Medico-legal consent is very important. Record the vision and details of injury, the previous records, medical and surgical prophylaxis, antibiotics. Don't forget tetanus, investigations, X-ray, ultrasonography, CT scan, ferro-eye status, systemic diseases, drug allergies, and gentle examination, fundus examination, slit-lamp examination, gonioscopy if you suspect an angle foreign body, and refer to VR emergency, inform the duty consultant after OPDRs, and in the look for the ultrasound biomicroscopy, CT, orbit and brain, suspected foreign body, helical CT without contrast, and no MRA if you suspect a metallic foreign body. All these are the preferred practice. Admit all cases, suspect frank endophthalmitis, tetanus prophylaxis, IV antibiotics, consent for surgery, operating surgeon to see the patient in the ward prior to surgery. Immediate surgery, elective surgery, you can do that as far as intraocular foreign body is concerned. Ocular surface squamous neoplasia, tumors of the stratified squamous epithelium ranging from benign disturbances of epithelium maturation to frank malignant. And you can see patients can present with conjunctival mass, irritation, common systemic predisposing factors, exposure to ultraviolet light, HIV positivity, xeroderma pigmentosa, human papilloma virus, and location, bulbar conjunctiva, appearance, gelatinous, size of tumor. All these are there, and the investigations which are there as a part of the preferred practice patterns for these patients. Surgical excision, the treatment of choice, excision or lesion with a safe margin 2 to 3 millimeters, cryotherapy to the limbus and conjunctival margins. These are all preferred practice patterns which are followed and practiced by many ophthalmologists and recommended. So this is for the particular thing. How to, in glaucoma, how to determine the target pressure, minimum of 20% reduction in the baseline IOP. You require a target IOP to prevent progression, and you can see the visual field loss from 40, mild, moderate, and severe, depending on the target initial average IOP or the presenting IOP, and the target IOP is reached depending on whatever thing, and how to follow up these patients. If the target, there's no progression of the damage, you can have less than duration of control less than 6, then you can do it to follow up to 1 to 6 months, then or 3 to 12 months, depending on the what you call the response of the patient and the progression of the disease. So you also reset target IOP if progression is present in spite of reaching the previously fixed IOP, and institute therapy accordingly. Ensure compliance and ask for adverse events with the drugs, maintenance of disc drawings and descriptions, and follow-up of the fields. Stable field testing once a year, unstable 2 months to 6 month evaluation. PPC, the PCR, the preferred practice protocols. Small PCR convert into the posterior capsular rhexis. Do not pull out, inject viscoat through the side port when you have a PCR. Always use preservative-free tricot to delineate the vitreous. Bimanual automated anti-vitrectomy, either through a limbal or a pars plana. Remove the vitreous first and then remove the cortex and the epinucleus. Appropriate IOL. Suture the wounds when you have a PPA and a PCR. Again, preferred practice in postoperative endophthalmitis. Do an AC tab, just broad guidelines. Vitreous tab, intravitreal antibiotics, depending on the grade of the vitreitis and the vision of the particular patient, or the advanced cases, you can do a pars plana vitrectomy as well. So this is just to show you, and these are my acknowledgements. Dr. R.T. Mohan Kumar, VR consultant Rajan. She's done a lot of work on this preferred practice patterns, and she is in fact one of my co-authors in my Color Atlas book of the retina optic nerve as well. Thank you, Maharashtra Ophthalmic Society, for the wonderful opportunity and the patient attention as well. It's always a pleasure to come back to MOS and mingle and interact with all of you. And just to show you, just to tell you that I'm also need your blessings as a candidate, as a Vice President candidate for AUIS 2022, seeking your blessings and support. I'm always available, accessible, and approachable. Thank you very much again, Jignesh, for this wonderful opportunity.
Thanks a lot, Dr. Mohan Rajan, my close friend. Any difficult, it was one of the most difficult topic. I've asked so many people. You readily agreed, and the way you have showed us the way, it is fantastic. Even I had learned a lot of new points today through your presentation. So thanks a lot for illuminating us on such a difficult subject in a very nice and lucid way. Now I think we'll have a panel discussion. Before that, I think I'll tell Dr. Praveen Patil to introduce our co-panelists one by one, and then we have a discussion.
Yes, sir. I'm sure our panelists, academic committee members, and our audience are having a lot of questions regarding this topic, as this topic is generally not discussed during conferences.
Correct.
So before that, I would like to introduce our eminent panelists, Dr. Rajul Parikh sir and Dr. Akshay Nair, and then we'll move ahead with question and answer session. So Dr. Rajul Parikh sir is director of Sriji Eye Clinic and Palak's Glaucoma Care Center. His main areas of interest are glaucoma and clinical epidemiology. And he is Associate Advisory Board Member, World Glaucoma Association since 2005 to 2018. He is Society Editor, International Glaucoma Review since 2018. He is Member Education Committee of World Glaucoma Association since 2018. He is Glaucoma Section Editor, IJO, since from 2007 to 2013. He is having 80 publications in index journals and non-index journals, and contributed in World Glaucoma Association consensus books. He has authored 17 chapters in various ophthalmology textbooks. And regarding Dr. Akshay Nair, he has done his DNB from Shankar Nethralaya, Chennai, and he is a oculoplasty. He has done his fellowship from LV Prasad, Hyderabad, and he has done ICO fellowship from New York Eye and Ear Infirmary at Mount Sinai, USA. His main areas of interest are ocular surface tumors, eyelids, and periocular aesthetics and endoscopic lacrimal surgeries. Also, he is having 100 plus published peer-reviewed publications and 16 book chapters to his credit. And he is reviewer for more than 30 journals. Over to our panelists. We can start the question and answer session now.
Right, sir. Thank you, Dr. Mohan Rajan, sir, for that amazing talk. I think, like Dr. Jignesh sir said, it's a difficult topic, but I think it's needed because very often we come across a patient who is in a particular. Now, say for example, simple thing. We have a patient who is come for cataract surgery, profound vision loss, 624, 636. Pre-op, he says, I have some watering. They find that there is a blocked duct. Now, the cataract surgeon will refer it across to me and says, you need to do a DCR before surgery, before cataract can be done. And so many questions come up. Can the other eye be operated? How soon can this DCR be done? How soon after a DCR can a cataract be done? And we don't have answers to that in any textbook. Okay. And I think one point that you underlined is that there is a need for this. You can call it anything. You can call it a special interest group. You can also call it a consensus statement or a preferred practice pattern. But at the end, if we end up operating a DCR and within a week a cataract is done, and by some quirk of fate, twist of fate, that guy lands up with a post-op end-off, there has to be some document that says that, no, this is the consensus amongst the expert group of doctors, which is why what he did was right, and that holds in the court of law. So I think that hits you said it right. There has to be some, the need for this is overwhelming, but I don't think there's enough people to shoulder the responsibility and come up with this. So my question to you is, how do we go about it? Because this can be done state-wise, it can be done country-wise, it can be done specialty-wise, or like I said, you catch one scenario, ptosis in children, timing of surgery, lacrimal surgery before cataract. scenario wise. So how do we start? What do you think will work?
You asking me, Akshay?
Yeah.
Yes, sir.
Okay. Yeah, actually, I think it's a very important thing. For any project, especially when you have a project like this, a program like this, there will always be a starting trouble, teething problems. So this is because this is a very, very difficult path to venture into. And what I would suggest is, see, we have we have we have to identify, just like the IPL team, they have identified 590 players, okay, who are in the auction. Similarly, we need to identify about 100 ophthalmologists, okay, 10 ophthalmologists from each group. That is, for example, oculoplasty, 1, pediatric ophthalmology, about 10 people, and glaucoma, 10 people, medical retina, 10 people, surgical retina, 10 people. Like that, about 10 groups we need to form. Each of these 10 groups should have 10 super specialists who have done their fellowship in cornea or refractive or oculoplasty. They're all specialists and experts. And these 10 subcommittees have to be formed. Okay? And that is the only way to start. And these 10 people, okay, and you need to also give them some topics. Okay, these are the 10 topics or 20 topics. I want you to formulate preferred practice guidelines for these 20 topics. For example, Akshay, very important practical problem. Okay, if I have an NLD block, if I have a patient with a lacrimal sac, so you refer it to the oculoplastic surgeon and DCR when to operate, whether we should operate now or we can operate the other eye. So many questions are there. So all these things, common clinical situations we need to do. Okay, common clinical situations, what the ophthalmologist or a day or a individual practitioner is facing day to day. For example, whether we can operate a patient who's got a chalazion, whether I can do a cataract surgery on that patient. Okay, he's got a chalazion, whether I can do a cataract. Many people come and ask me, I have a chalazion, and whether I can do the surgery on the patient. Whether I should take a conjunctival swab for the patient preoperatively. Okay, and all these things. So these are some of the common things. So look at the common topics and ask the 10 committees to dwell into these common topics and formulate the guidelines. And the story does not stop there, as I told you. Once they formulate the guidelines, these guidelines have to be audited by an internal as well as an external audit. Internal as well as external audit. Just like you have an audit for your hospital, when it comes to NABH or whatever it is, the internal audit as well as external audit has to be there in this committee. Because there can be some other person who has got probably a better way of doing it outside that. So we need to take that opinion also and see. That is the only way to start. So first thing is to form the committees and begin the whole process. And the committee should formulate. And these committees, we have to give these topics. These are topics I want, preferred practice guidelines. Because if you go from A to Z, there are probably 1,000 conditions which are there, and it's very difficult for them to do it.
Quite right.
That is my way of analyzing this, Akshay. If you have any other different method, you tell me.
What is Dr. Rajul Parikh's opinion on this? Rajul?
I think Dr. Mohan Rajan, he's absolutely right what he said. And we followed the same pattern. So because glaucoma guideline is going to release within a month or so,
yeah, you told me.
We had prepared the 17 sections, and we had 3 coordinators doing 6 sections. And then every group section had a chair, co-chair, and 5 or 6 faculty, all the glaucoma specialists. And initially, this coordinator looked the matters. Then once we finished each section, it went to the internal reviewer. That was among the the people who were involved in the different sections. So after the internal audit, we had selected 20 who had agreed to review the international glaucoma specialist. And the part of this faculty was the World Glaucoma Association, the education committee. So they also reviewed. And once it came back, then we incorporated the suggestion, whatever we felt appropriate, of course, because some of the Western guideline, we have to look the Indian approach also. The Indian scenario is a little different. So we incorporated and then we finalized. So it was a big task. It's a really big task, huge task, because the last full 1 year we spent only making glaucoma guideline.
But which are the topics you took in this?
Pardon?
Which topics did you take? Our whole glaucoma?
So we covered everything. It was glaucoma, so everything. The 17 sections, we had, first section was epidemiology, very brief. It's not a textbook, so only briefly. The second was the important RCTs. The third was diagnostic, because that is one of the most important thing, where we covered gonioscopy, IOP, perimetry, imaging, progression, then definitions. Then we went into the ocular hypertensive medications, lasers, surgery, principle of medical management. Then we went to section wise, like management of ocular hypertension, management of POAG, management of PACG, management of PACD, secondary glaucoma, congenital glaucoma, the little bit of screening, and then the future. What are the options we may have? So everything was covered. And then last section, and each section had a, what Dr. Mohan Rajan was saying, we had the important recommendation that was based on the grade, the evidence. Then details, but everything was point wise, not in the text format. As far as possible, point wise, tables, figures, and important FAQs. So what the common questions the general ophthalmologist or the resident may have. So we try to cover that way.
Fantastic. When is it getting released, Rahul?
Oh, we released. Inauguration was done in the last GSI conference.
In Assam.
So, but now, so the printing has started. So it was done with the Kugler publishers. Kugler, they have a huge publication along the glaucoma fraternity. Like most of these World Glaucoma Association consensus booklet is done by Kuglers. So they are very good in glaucoma. So now the print version will come sometime, I think, in the March next month.
It will be preferred practice guidelines in glaucoma. That is how
it is. Guidelines.
Recommendation.
So we discussed, Dr. Taswara, the preferred practice would cover each topic in more detail. Guideline, like Academy has done, they have covered each, like VOAG only would be 30-40 pages.
Okay.
They have huge, they write down everything in details, epidemiology in detail, the risk factor in details. In guidelines, we should be more specific. It's like the glaucoma guideline is going to 300 page, and when I got the hard copy, I felt that I should have cut down another 40-50 page. So the guideline should have been little bit as slim as possible.
More precise.
Yeah. So some of the sections, like PACD was done by Schaefer, is very precise. Some people had written long. I tried to cut down, but it was sometimes difficult. Like secondary glaucoma going little bit longer, but the guideline should be as specific to the point. And preferred practice, when we write down, we should be more elaborate. We can be more elaborate.
Detailed.
Yes.
That was the reason actually I had taken you in last time when we had an internal meeting about the MOS academic committee. We discussed it out with Dr. Karandikar. I would like to have Dr. Akshay's view how it is going to help us in case we go ahead and do it as a common practitioner. Akshay.
Yeah, sir, I think first now I can see like how when you asked Dr. Mohan Rajan sir, his guide for setting this up was to set up auction teams like IPL. I think this is the reason he has won his 60 OPLs, because his mind is thinking in the IPL, OPL direction. Anyway, no, but I think you, like you said, one of the things that I think we can also take a leaf out of the book is the literally and figuratively is what AIOS had earlier started, and they were very regular with it. But I think the post pandemic, since all of us are overwhelmed with sitting in front of our computers for webinars, that has taken a pause. The AIOS CME guidelines, they were actually very specific.
Very good.
It fit in the palm of your hand. And also, I think even after that, when Dr. Ramamurthy was the president, they had 2 issues of a ready reckoner, which all of us had contributed bits and pieces. That was also a good, even if that can be refined, just split up section wise, they already have a base on which we can build. And, I think we can even combine it that way, where we can take experts, assign each topic to one state society. And that state society can coordinate amongst themselves and do this. So then it won't even take that much long. Within a matter of 6 months, every specialty can be dealt with.
How will it be helpful to the common practitioner, Akshay?
Because nowadays, all of us, I think all of us are doing everything. All of us are, most of us are seeing patients across specialties.
Absolutely.
So now if I'm seeing a patient with, like, for example, and I'm being honest about it in front of everybody, my scariest thing is when I see a child walking to the OPD and there's no other ophthalmologist in the hospital. Like, what glasses do I prescribe? At what age? So because it's been a long time since I've done pediatric refractions and things like that. So to have something as, ideally I would have, have a pediatric ophthalmologist see this. But, we're becoming so specialized
narrowing.
we are knowing lesser and lesser. So something as simple as a child walking in, when I should be happy, I get scared. So for, like you said, the most commonest of things we need to know. We don't, we're not even talking about treatment of acanthamoeba keratitis. What is the glass prescription based on the cycloplegic refraction needs to be given to a 6-year-old? Those guidelines, which even, there are tear out sheets that can be stuck or kept. It's also going to be a guideline for residents who are going to study for their examination. This will obviously cover common topics that examiners like Mohan Rajan sir and you will ask students.
That's nice, I think. So definitely it's going to benefit once we take this project in hand. And during my tenure, I think the specific topics we'll take, and common to all the ophthalmologists is what I plan to do it. So it's a good beginning with Dr. Mohan Raja's presentation today. Praveen, do you have any questions coming up from the YouTube and all people would like to ask the panelists?
Jignesh, I would like to ask the panelists here.
Yeah.
Can I ask?
Yeah, very much. It should be an interactive session. You within yourself and from outside, all questions have to be taken.
The problem with the Shankarnetrala book you have seen, it's a little voluminous.
Correct.
If you go through it, it's a little voluminous. I'm not sure how many ophthalmologists across the country will be able to go through everything. Okay.
Correct.
And what we have to probably aim, I'm not sure whether it's feasible. It may be difficult because it's a double-edged weapon there, as Rajul rightly said. Probably it should be a very, very concise and which you can just put it in your pocket.
Yeah, it's like a ready reckoner.
Ready reckoner for a concise thing. For example, if I have a patient who's got an intumescent cataract with a phacomorphic glaucoma, okay, what is the preferred practice? What should I do? Whether I should do a PI or whether I should do a phaco for this patient or something like that. I'm just giving an example.
Or something. Correct.
Yeah. So, what is common? Look at the common things, what the common practitioner will see.
Correct.
Right? Like Akshay was rightly saying, how to do a basic refraction, how to give a spectacle for a child.
Yeah.
It's a big nightmare for all of us.
Yes, very much. On an open forum here. It is the need of the art to have it.
How much to minus, how much to plus. All these things. So, very common things. See, common things are more common. Okay. So, I think we should first aim at common things, be very precise and to the point, and bullet points, no text, bullet points only. 1, 2, 3, 4, 5 for a intermittent cataract. 1, 2, 3, 4, 5 for a refraction in a child. That's all.
Correct.
I don't know. I want the opinion from other panelists for that.
No, I think what you said is right. And sometimes it just takes, like you said, that rocket principle. Unless there is fire on the backside, it doesn't go up. So no, because when the pandemic lockdown first phase came, immediately, AIOS decided we needed guidelines for every specialty for COVID care. The deadline for this consensus statement is next month. And you had groups of different specialties. There was GSI, there was SPA, OSI, there was Oculoplasty Association of India. All of them, each team had gathered 10, 15, core committee people, back and forth emails. In 15 days, the guideline consensus statement for how to manage their specialty care during the lockdown with COVID precautions. And it came out in the subsequent IJO in, I think, April or May of 2021. 20. So, we really, unless there is some pressure on us, none of us are going to sit down and get it done. So, Mohan Rajan said that can be one of your planks for the campaign for 2022.
Absolutely. No doubt. I think that's a very good suggestion, actually. Thanks a lot. Yeah.
Rajul, your view.
Another thing, Akshay, the deadline is fine, but we also have to look the real evidence. So, that time also I had actually pointed out for the glaucoma things, that lots of things for the COVID precaution, what the guideline mentioned was not correct. So we have to be very careful when we write down, because the sodium hypochlorite 0.5%, 1%, it was mentioned in GSI, the glaucoma thing which published in IJO. And I wrote a 2 letter to editor also for that, because 0.5 is really corrosive.
Yes.
It is really corrosive. And I had mentioned that time also 0.5 sodium hypochlorite cannot be used. 0.1 is maximum allowed, and there are various publications. And I pointed out to the AIOS, I was not part of the glaucoma thing. I pointed out to GSI, and they said, no, it is not like that. 0.5 is not corrosive. And there are so many people's street lamp got malfunction, and because of the inappropriate guidelines. So we have to be very careful what we write down. So sometimes, we don't realize. We look only one article and say 0.5%, but the 0.5%, so, in general, I'm just giving one example. So sometimes we should not hurry up the things. We really have to look the evidence that what we are writing and why we are writing. That we have to be very careful when we write down guidelines.
Praveen, any questions from the YouTube or this? You please ask.
So no questions from YouTube, but I think you should start with cataract guidelines first, because those are the most common questions. How much should be the blood sugar level, and how much should be the BP? These are the most common questions. And like Akshay said, we should operate if patient is having partial block, then we should operate or not. That is the most common thing we come across everyday practice.
Very nice.
Regarding IL power calculations also.
Correct. Especially in pediatric cases, we have different views coming up. So we definitely require preferred practice guidelines for this. How does it stand in the court of law? Can we have this, or it's not much of a use? What is the panelist view?
No, actually,
earlier also.
Definitely, it will have a very good saying. For example, this Avastin also, when there are a lot of problems in the Avastin, post-Avastin endophthalmitis,
off-label.
a lot of preferred practice guidelines were there, even from the US, that Avastin is a drug which can be safely used in the eye, though it is off-label drug. So I think it is definitely, when you have preferred practice guidelines, which has been recommended by a committee, and you are going to, it will definitely have some weightage in the court of law.
But
doctor, but we have to write, whenever you write down, it has to be very clear that these are just the guideline based on the expert opinion, and because the the MOS also has to be legally on the safer side.
Correct.
So people cannot say, that because MOS mentioned, we have done that.
Yes.
So I think most of the guidelines write down very clearly, this is the expert opinion based on evidence, but you have to use this.
Your discretion.
Yes.
Your discretion to take it.
It's only, no, definitely, yes. So what I'm trying to say is, if you have a preferred practice guideline and you are using something under that preferred practice guidelines, that is definitely better than situation, relatively better than not having a preferred practice guidelines to it. Am I right, Raju?
Yes, yes.
That is what. I'm not saying that is going to be completely this thing, but definitely there's some weightage will be there in the court of law.
Yeah, so I think this is what in the AIOS guidelines for trauma and oculoplasty for COVID, they had written that these are based on the information by whatever current evidence. It is a constantly evolving thing.
Yeah.
And expert panel doesn't warrant to the complete accuracy or the guidance, and they assume no responsibility for damage or blah blah blah. And we will not be party to for medical legal implications arising out of following or not following these recommendations. So I think at the end of the day, we have to also, I think, but that's fair because it's an attempt to help
people.
But you don't want that to be used as a double-edged sword.
Correct. What has happened nowadays, I'll tell you, different institutes have different level of teaching. So this definitely sets a normal, what I say, standard guidelines. It won't stand in the court of law, but it will help our fellow ophthalmologists, general ophthalmologists who are not good in all the subspecialties. So it's like a ready reckoner or standard guidelines or standard protocol will be of help, right? No?
Yes.
Each one of you. That is what I feel, and that is why I had that idea. Okay, why not go away with it? The way Dr. Praveen Patil said, the common subjects like cataract. I have ptosis in mind, oculoplasty, which I said, refraction. It's a very common thing. People now with the auto ref around, where people have forgotten refraction totally. So if they're already reading coming out, they put it on this and give the glasses. So that is another thing which I wanted the common topics to be taken. And that's why we wanted Dr. Mohan to give us a guideline, and excellent way he's given us how to go about it. Anything more you'd like to add?
Jignesh, I would like to add
go home message for, Mohan.
Jignesh, I will tell you this preferred practice guide. For example, I would say, see in, I do not know, in Nellore, there was a long time back in 2008, there was a big cluster endophthalmitis in one of the
2009, sir. Yeah, I was in SN that time.
2009 with Sai Murli, and subsequently 2012 we took over his hospital. Okay, in 2009 he had a cluster endophthalmitis, 65 cases, mainly because they were using the ringer lactate.
Oh.
Okay, and they blamed it on the ringer lactate. Okay, because the ringer lactate is not supposed to be used. It is used only for intravenous. And they said, ringer lactate, how did you use for the eye? And that is the reason for the cluster endophthalmitis. Okay. And only you have to use only balance salt solution, BSS. Okay. So that was the thing. It happened in all the cluster endophthalmitis, wherever it has occurred, it is all because of, they say it's because of the contaminated irrigating solution, which is ringer lactate. So many people, many ophthalmologists are of the opinion that, okay, if you use BSS, you are safer, because BSS is meant for the intraocular use, whereas ringer lactate is not meant for the intraocular use. Similar to Avastin, it is not meant for the eye. It's off-label use only. Similar to that, so they are the lawyers are fighting like that only. Okay, but what happened was the Arvind Eye Hospitals, this thing, they came out with a very huge study. They said we have done 100,000, 200,000, 300,000 cases we are with the ringer lactate, and we have not had even one single or only one or two endophthalmitis. Our rate is only 0.001% or whatever it is, and we are using ringer lactate. The same company which is making for them also, the Baxter, we are also using the ringer lactate only. And the thing. So immediately what they think that the court of law, because it's something like a preferred practice pattern by a big group, just like the World Glaucoma Association, what Rajul was telling just now, the World Glaucoma Association has approved that guidelines, which means that the supreme body has approved the
Yeah,
guideline.
it's an authority in glaucoma.
Similar to it, as far as all of us, the highest volume is done by the Arvind group. If Arvind group says, okay, ringer lactate can be used, and this is a preferred practice pattern in our Arvind eye care system across all the hospitals in our Arvind eye care system, and we have not had any clustered end ophthalmitis or anything like that. Okay, so immediately what is happening? The court of law, the lawyer is on the back foot now. So this is where I think the preferred practice pattern, something like this, will
We can help our colleagues when it is collectively put up.
Collectively
what is going on in our area, this has been followed by
so
all.
how many of you are using ringer lactate? How many of you are using BSS in this group?
I am using ringer lactate.
I am using BSS. But how many of you are using ringer lactate?
I am using ringer lactate.
I also use.
Yes.
I'm
Ravin also.
using
Rajesh?
BSS, sir.
Ravin, ringer lactate.
No, sir, I'm using BSS. I'm in
BSS.
Centurion.
Yes.
Rajesh, in your GMC?
GMC ringer lactate.
See, we are using, majority are using ringer lactate.
Ringer lactate.
Yes.
Okay.
Yes. In Pune, I have not seen a single, I mean, maybe some people excluding, majority are using either the ringer lactate. NS is stopped now.
That is
Initially,
why.
we used to use normal saline. So there is no longer this thing, but ringer lactate majority are using.
Yes. Similar to the Avastin. So majority are using Avastin. And
That's why they got
Avastin is
sick.
relatively safer. So that is become a preferred practice pattern.
I
So
think
you
Ramamurthy is
you cannot blame it.
presidentship.
Yes, it happened.
This was picked up as a big topic of level use of this, and it should be rectified by all the companies.
Yes,
I mean, they are this thing, what we say, government regulation. But it did not happen. Did they make it regular label or it's still off label?
No, it's off label only, but it is approved now.
Allowed. Okay.
Yeah, all the major institutes are using it. Shankar Netral is using it. L.V. Prasad is using Avastin. Chandigarh PGIMR, AIMS is using it. Everybody is using it. Avastin. Only thing is, they are using it on a single day. They are using that vial, or they are making it to what you call aliquots, and then using it. So it is a sterile conditions. Everybody is doing that. The technique of injection is also very important.
Different batches on different days, so that no 2 days have same continuous batches.
Correct.
So they pull up all the patients on one particular day and finish off the Avastin on that day.
Very good.
So in Shankar Netralia. So they are doing that. In every LVP also they are doing the same thing. So like that, if you have big institutions supporting this, and that is why we have to get these institutions also into the whole thing, whole ball game.
Can we do that way? Baba, we I have a group where we have about 5 oculoplasty, 5 glaucoma, and this. They work up the guidelines, recommendation, and we send it to one of the institute, or we do send it to the what we say in and out, both inside India and outside abroad also. Get the recommendation, then go sign a booklet, or we just take the recommendation and print it. What will be good?
I think so. That's the only way. We need to collaborate with bigger organizations or bigger associations.
Okay.
Bigger associations, international associations. For example, we can collaborate with the Asia Pacific Academy of Ophthalmology or the APSCR as far as cataract is concerned. Asia Pacific Association of Cataract and Refractive Surgery. And they have this thing, we can collaborate with them. And we can get their opinion also. They have a fantastic committee for that. You can have the ASCRS committee on cataract committee to comment on us. So they'll be willing to help also. Us. Yes, American Society of Cataract and Refractive Surgery, they can do that. ASCRS committee, which is formed guidelines for endophthalmitis. So one of the ASCRS guidelines is one of the gold standard guidelines as far as endophthalmitis is concerned. Yeah.
Absolutely.
So, yes.
Akshay and Rajul, a word from you before we sign off.
I think we covered the topic very well, comprehensively.
Praveen, from you?
Sir?
No questions?
So no such questions. He has already
Rajesh?
told everything.
Yeah, fine, I think. Most of the things have been covered well.
It has done a great job. A short intro about him has been left out from me. Sorry for that. He is an MBBS, DNB, and a TOMS and FCPS. He is a VR surgeon. from Sri Venkatesh Eye Institute, Latur. Done his MBBS from MISR Medical College, Latur. DOMS from HPSI. And FCPS from JJ Hospital, DNB from Delhi, and a long-term PR fellowship from Sri Ganpati Netralay. So we had a very expert moderator today with us. Sorry to have introduced so late, but people should know about you also. So a big thank you for all the three faculties who had joined, moderator, and of course Dr. Rajesh Joshi and Rajiv Mundra being part of this show. We have put in a very nice message how to go about it, Mohan. You had made it was very difficult when we had a for academic meet. Me, Dr. Karandikar, Rajul had discussed at length. They are coming up with the glaucoma guidelines. So this is a little more in depth that we are going to go about it. And thanks for accepting my offer, invite also, coming and helping us out on this topic. Akshay, very good inputs from you. And Rajul, as usual, is always there. And Praveen, you have done a great job as a moderator. And for vote of thanks from you also, Dr. Rajesh Joshi, to sign off. Thanks the Enrolled people. Yeah.
I think it's going to be ongoing process, and we need to have guidelines for common diseases.
Correct.
Thank you, Dr. Mohan sir, for guiding on preferred practice pattern. With your valuable inputs, we will be able to form guidelines at least for some common diseases.
Yes.
Yeah. I'm also thankful to Dr. Rajul Parikh, Dr. Akshay Nair, and Dr. Praveen for joining, participating, and giving valuable inputs. My special thanks to our vibrant president, Dr. Jignesh Taswala, for keeping all of us busy on such an important day. Dr. Rajan must have received 100 to 200 calls on his mobile. Many thanks to Entor for the technical support. Thank you.
So nice of you. We can stop the recording, Sayyed.
Yes, sir, just a moment, sir.
Thank you, Jignesh.
Yeah, thanks a lot.
Jignesh, thanks a lot.